and we will get started. So good morning to everybody from the West Coast. Good afternoon to those on the East and everyone in the middle, whatever time of day it happens to be. This is the final of our 4-part Framework for Action webinar series, falling into place, aligning payer strategies for population health. I am Ginny Weir, CEO of the Foundation for Healthcare Quality, and I've been the director of our state's BRIE Collaborative for the past 8 years. And this webinar series has really been a great partnership between our BRIE Collaborative at the Foundation for Healthcare Quality and the Washington Health Alliance. We are also very grateful for your commitment to high-value care in our Pacific Northwest region. So our webinar today is designed to help payers and providers identify ways to work together to transform high value into value-based payment models and improve health outcomes. Moving our healthcare system from fee-for-service to value-based care has been a cornerstone of our work within the BRIE Collaborative, and we've woven value-based reimbursement strategies very explicitly into our 5 bundled payment models and also into clinical guidelines ranging from hysterectomy to palliative care. So this 4-part series are organized around the 4 accelerators for change that we identified in late 2020's Value-Based Summit, a series of conversations really focused on specific steps we can all take around the accelerators for change, whether we're clinicians, whether we're embedded within health systems, working at healthcare plans, or serving as purchasers of healthcare. We really all have a role to play to accelerate these changes that we want as fundamental to our population's health. So January this year, we focused on social determinants of health, April on interoperability, July on quality measurement, and now October on aligned payer strategies. And really each of these present an opportunity for our healthcare ecosystem to do together what none of us can really do alone. So my personal goal is that we can build Washington into the state that inspires jealousy, but also change nationally. I want people to want to be like us. And we'll start today with Dr. Lisa Watkins, the Milbank Memorial Fund, move on to a state spotlight, this time on Ohio with Tiffany Mattingly from the Health Collaborative. Our own Dr. Emily Transu will outline our Washington State multi-payer primary care initiative, and then we'll facilitate our boots on the ground panel. In 2022, we'll see us focus on these same 4 core topics from the perspective of change in action. So stay tuned for our Alliance and Foundation listservs for more details. Before we begin, just a few housekeeping items of note. Again, you're all currently on mute and will be throughout the day. During each presentation, please feel free to write a question for our speakers into the Q&A at the bottom of your screen. Please enter any technical issues into the chat box, and we will be monitoring both throughout the webinar, but really looking primarily at that Q&A box. This webinar is being recorded, and a link to the recording along with today's presentations will be emailed out after the webinar concludes. You may have noticed the closed captioning at the bottom of the screen. In the spirit of inclusivity, we'll be using this feature for all webinars going forward. If you would like to view and read the full log of this transcription, please look to the bottom of your screen and click on the far right option, View Transcription. So now it is a pleasure to introduce Dr. Lisa Watkins, a director and one of the founding members of the Milbank Memorial Fund Multi-Payer Primary Care Network, a consortium of 8 state and regional multi-payer programs designed to transform primary care. She is actively engaged in advocacy for new and continued support for these efforts and other innovations at the state and federal levels. Dr. Watkins is the former chief of operations for the Vermont Blueprint for Health. She received her medical degree from the Perelman School of Medicine at the University of Pennsylvania and her BS from City College of York. And I will turn it over to you, Lisa. Thank you.
Thanks very much, Ginny, and it's a pleasure to be here. I'm hoping everyone can hear me okay right now. Is that correct? Great.
You can.
Oh, great. All right, I will share my screen. Okay, well, thank you very much for this opportunity. It's always a pleasure to have the chance to speak with people who are doing the work, the very hard work on the ground. And I really relish the chance to hear more about the work that's happening in Oregon and Ohio through this discussion. I look forward to the days ahead, like the old times, when we'll be able to do this kind of meeting in person. But for now, the technology is working pretty well. So thanks everybody for patience and sitting in front of your computers for yet another couple of hours. So I was asked to address this group today to give my sense of the national scene, the landscape, as it were, around multi-payer primary care in our country at this point. What I'd like to do is to give a little bit of history first about the Milbank Memorial Fund and our role in supporting this kind of work, some specific examples of collaborations that have been in progress now for well over a decade between the Innovation Center at CMS and the states and some regions. And then a little bit of talk about what we see in the future. Certainly some things we know are already rolling out, and certainly some perhaps speculation about what's going to be coming in the future. So first, I'd like to just talk a little bit about the Milbank Memorial Fund. It is a very old foundation. It's an operating foundation, so we don't give out grants the same way an organization like the Commonwealth Fund or Robert Wood Johnson does, but instead we have more of a mission that's involved in really providing the best evidence to people who are making decisions about how to use scarce resources in the pursuit of increasing the quality of population health. We have three sort of major areas of work. We have a high quality evidence-based report machine, basically in the Milbank Quarterly. We have a peer-reviewed journal. It's very specifically around population health and health policy. There's a lot of opinion pieces that come out of that, but nonetheless, it is seen, as is the fund in general, as a very bipartisan and neutral organization. We do, as I said, convene state health policy decision makers on issues that they identify as important to population health. Again, this is very, very consciously and frankly jealously guarded reputation as being truly nonpartisan. We engage with the full spectrum of the political set of opinions, and we really work closely with both people in gubernatorial administrations down the line and state legislatures. We also have been building communities of health policymakers and to enhance their effectiveness. And that's really the work that I have been engaged in more directly, which has been working with various states and regions to help them learn from other regions. Essentially, we convene the conveners and bring people together to be able to share their successes, their barriers, trying to steal shamelessly from each other, frankly, in order to get the best ideas and try to put them into place. So the multi-payer primary care network supports, as I said, those local multi-payer primary care transformation efforts, bring together neutral regional conveners, interested commercial and public payers, and sometimes others that have other specific interests, such as health information exchanges, all payer claims databases, et cetera, to share experience, information, and best practices. And what we want to do is to facilitate and support regionally based multi-payer primary care transformation. In the past, we've certainly done a lot of in-person gatherings. We are looking forward to doing that hopefully in the next 6 to 12 months. In the meantime, we run a series of monthly meetings. We have quarterly virtual seminars where we bring in experts on specific topics that our members are interested in learning about. And we also have been very fortunate to, because of our history of bringing people together in person, I think there have been a lot of working friendships, working relationships created with people from all across the country. And there's a lot of interstate and interregional sharing of information individually, which sometimes I hear about, sometimes I don't. It's really nice to know that that is going on. So our underlying assumptions, which are really based on the work of the great Barbara Starfield many years ago, is that reformed primary care is essential to a high-performing healthcare system and can improve the health of populations. We have taken it further to say that to achieve reformed primary care, you really need to align the actions across multiple payers, ideally all payers. We recognize that that is a big lift, and it will probably take some time to get close to that, but nonetheless, that is a goal. And then, of course, the work of transforming primary care must occur at the local level. And local can mean regional, it can mean statewide, it can mean just a city. I mean, it really, it can be many different things, but it's very clear that where the rubber meets the road is where people live and work. Now, that's not to say that there isn't an important and frankly, I think essential role for the federal government and its agencies to really serve as thought leaders and frankly, bringing their vast resources, which brings with it a great deal of credibility to any innovation that's taking place locally. And so with that in mind, we've had the really wonderful opportunity to work with our colleagues at Medicare, specifically at the Innovation Center at CMS, which I refer to as, this is a full acronym slide, but CMMI is its nickname. And they have been really at the center of a lot of the multi-state programs that have had some really significant success, and certainly multi-payer programs giving them a little more energy because of frankly, because of Medicare's participation. And that has now spanned over a decade. As I said, the original program that we were involved in Vermont was the Multi-Payer Advanced Primary Care Practice Demonstration. That involved 8 states. Then since then, there have been 2 more programs, and now we're in a 4th program, which I'll describe in a little bit later. But what I'm going to do is concentrate a bit on our experience with these 3 programs, specifically the Comprehensive Primary Care Initiative, which ended in 2016, and the Comprehensive Primary Care Plus program, which is going to be sunsetting at the end of this calendar year. So this is just a sort of cartoon-like timeline, but this just gives you how long we've been doing this. And the Milbank Memorial Fund has been a part of that since 2009. I mean, really since the very early days when Obamacare was passed, and so there was all this excitement and the creation of the Innovation Center and the opportunity for some upstart states like Vermont, for example, to engage the federal government to say maybe Medicare could be one of our participating payers in our multi-payer activities. And Milbank was very helpful in bringing states together that were doing that work and advocating for that. And as you can see, these programs have been in place, and there's been sequential variations over time. Once again, I apologize for these acronyms. MAPCP refers to the Multi-Payer Advanced Primary Care Practice Demonstration. That was a multi-payer program where Medicare actually came in as a payer participant, and essentially modified the way they were paying for primary care to meet the state's pilot programs. Comprehensive Primary Care Initiative and the Comprehensive Primary Care Plus programs both had more specific design from the Innovation Center, and but created an opportunity for multi-payer involvement in a certain number of states or regions. And then Primary Care First, which began this last January and is currently in progress, is yet another variation on that. All of these programs have specific attributes that really enforce that the payers at least try to work together to align the way they measure quality, the way they pay to the practices. Nothing is 100%, but these are earnest and important attempts, and frankly, important models for us to learn from. This is a map that just gives you some sense of the states and regions that are involved in these multi-state, multi-payer primary care transformation programs. And this is actually combining the Comprehensive Primary Care Plus, as I said, which will be sunsetting soon, and Primary Care First, which is underway right now and will be for the next 4 years. So this is not the whole country, but it's 26 regions, most of which are statewide. I think maybe 5 or 6 are in specific geographic regions within states. So this is an important question. Is this making a difference? Are we seeing transformation have an impact on the quality of care that patients receive? Is it changing the quality of the work life for the people who are delivering that care? Is it having an impact on other measures such as utilization of expensive services and is it having an impact on cost? I want to preface this before I go to the next slide that I think all of you are aware that the general consensus has been that the programs such as CPC and CPC Plus have not been successful in terms of a return on investment. I would like to make it clear that the evaluation that's done and is still in progress for both of those, well, for the CPC Plus and now for primary care first, as we move into that phase, are looking specifically at one population, which is the Medicare fee-for-service population. The evaluations that have been used to determine whether or not this is worth the effort and resource investment have not looked directly at the other populations in this vast multi-payer work. So commercial payers, state Medicaid agencies, all of that is not being evaluated directly by Mathematica in their extremely detailed and important evaluation. So the next few slides I'm going to be showing you are looking at a couple of the regions that we've had the opportunity to support some of the work to investigate that and try to understand what the impact has been on a broader set of people. So a paper that we had published, I think it was not this past summer, but the summer before, was from Arkansas at the University of Arkansas, as well as the team at Blue Cross Blue Shield of Arkansas. And they really wanted to understand what they surmised and then were able to do in much more in depth was whether this was having an impact on cost. The particular practices and beneficiaries, members that were evaluated had been involved, most of them, in several years of import of these programs. So it wasn't just over a 1 or 2 year period and then trying to assess the impact of the program. So you're looking at starting with the CPC Classic, which, as I said, goes back to 2000, I guess 2012 or 2013. And then looking over the course of multiple years. And what they saw was that there was an ever increasing benefit in terms of the cost that they could measure per member per month, and also per quarter, as this slide shows. And I think that this is an important piece because it illustrates how much time this takes. It's very hard to demonstrate, in fact, impossible to demonstrate a return on investment in the space of a 1 or 2 year period. And it's understandable that everyone would like to see that, especially if there's an election that's hanging overhead. But I think that this does take time, and this study we felt really reflected that important information. This was interesting looking at Oklahoma, and when they were doing their CPC, which is the previous iteration, they had a pretty impressive work on their quality, and they were able to demonstrate a net savings per beneficiary per month of almost $35. In comparison to the rest of the Comprehensive Primary Care Initiative regions that overall, this is an aggregate figure, $13.54. That's looking at all of them combined. So overall, yes, the whole program did not save any money, but there was ample evidence that in Oklahoma, they were able to do this. This has not been dissected, I don't think, to the point where everybody knows exactly what happens, but there's a great deal of opinion that this is a reflection of an extremely efficient health information exchange and information sharing that was able to be facilitated in Oklahoma through My Health Access. It's in the living room. Sorry. Our friend Tiffany Mattingly is on the phone. I'm sure she will recognize this very quickly. This is work that was done in Ohio. Ohio had a very large number of payers, continues to have a large number of payers in their comprehensive primary care work, and a great number of practices. They were able to demonstrate that ambulatory care sensitive conditions was something that really could be demonstrated to show a decrease, especially in Medicare Advantage, in terms of occurrence and resultant cost. And there's another study that's actually underway that we're in the process of reviewing, which we're very excited to see as they're looking over the next few years in Ohio. This is another study that we published on behalf of our colleagues in Oregon. Again, this is another state that's been involved in the CPC Plus work. They, previous to that, they were involved in the Comprehensive Primary Care Initiative, the first iteration of that. They have a large number of payers engaged, and they were looking at their data and saw better measures in terms of quality, including breast and cervical cancer screening. They were able to show positive trends in emergency department use and avoidable emergency department visits. And they were also able to demonstrate practices had a lower per member per month adjusted claims-based costs. And this is among a commercially insured population. I want to bring Rhode Island into this discussion. Partly, we have a very long-standing local convener in the Care Transformation Initiative of Rhode Island, CTC Rhode Island. These are individuals working for an organization that has really brought together their multiple payers over many years. And they have investment from every health insurance plan in the state. So it really is truly a multi-payer effort. They've been able to demonstrate lower costs, and they also have an interesting regulatory environment in which there is a required measurement of primary care spend relative to the total spend of in healthcare, and they also have a required increased target. So they've moved from an initial 5% of healthcare costs being in primary care to closer to 10%. I'll just put in, I think most of you know Chris Kohler, that the president of the Milbank Memorial Fund was previously the health insurance commissioner for the state of Rhode Island and was responsible for creating that mandate. So I put this up here because I think this is creating a national conversation, and I think it's an extremely important one. So the National Academy for Sciences, Engineering, and Medicine published this consensus study report, Implementing High Quality Primary Care. It has a great deal of information that I won't go through in any detail in this talk. I want to leave plenty of time for your local discussions. But this is an important piece. If you haven't read it, please download it and read it. And this really makes the case for very specific ways to improve the quality of care. And one of those pieces is truly talking about a multi-payer environment, that you can't expect an individual practice to have to modify everything they do based on the dozen payers that they interact with. So this has been making the case for that, and there's a great deal of interest in this nationally. So my last bit of the discussion is really just to talk a little bit about what we see moving forward. As everyone knows, we had an election with a change of administration. President Biden had the opportunity to appoint different people in leadership positions in HHS. And one of those people who was appointed and confirmed is Liz Fowler, who was the director of the Innovation Center at CMS. She's been quite forward about her view that multi-payer is very important, and they are undergoing what sounds like a really intensive strategic evaluation to figure out how to make their alternative payment models move forward and to really sustain modification, and especially looking with the health equity lens. Primary Care First, which is the current only program for primary care to participate in terms of an alternative payment model similar to CPC Plus, is currently the only opportunity. Our understanding is that there is a great deal of work determining frankly, developing and will ultimately be rolling out another type of program that may be open and easier for many primary care practices to participate in. Primary Care First requires a significant taking on of risk in terms of income. And it's not clear that all primary care practices, especially smaller ones that are independent, be they rural or urban, there may be more of a challenge to participate in a program like that. So that's been recognized, but there is no set plan yet. And that just brings me back to one of my original statements, which is I think that the work really has to be done at the local level. And very excited to hear more about what Tiffany is doing in Ohio. And I know you have a great deal of time to hear about the important work here in the state of Washington, and is certainly an exemplar for the rest of the nation in so many ways. So thank you very much for this opportunity, and I'd be glad to take questions.
Thank you, Lisa. We had a quick question. The color code on a bar chart you referenced, I think it was one of the first examples. What is there a meaning?
Yeah, I think, is it this one? Would that be the slide? I assume that's it.
Yes, Arkansas.
Yeah, I think that was, I actually don't know. And they're all different colors. I think they were just to distinguish them from each other.
Gotcha.
Yeah, I don't think there's no legend for the colors. I think it's a decorative effect.
Perfect reason. Another question that came into the Q&A: when reductions in cost are achieved, who in the system experiences reduced revenue, and how will they resist getting less revenue?
That is such an important question, but also a philosophic one. So I mean, my understanding of that is that their primary care is currently underfunded. The salaries, resources really are skewed towards specialty services, hospital costs, imaging, and procedures. And if primary care can be supported further to have an impact on whether someone is admitted to the hospital or goes to the emergency room, then admittedly that takes money away from the sort of bread and butter of the hospital ER, but that does save the system money. But that's I'm not sure I'm really answering the question. I'm not, but that's my current answer.
We had another question come in. Can you please share some of the results for Colorado? What, if you happen to know offhand, and what worked and what didn't work within CPC Plus?
So I actually don't have that information right in front of me. I would be glad to, whoever that is, if maybe someone could send me an email, and I'd be glad to send that, because we do have access to it. Colorado had, through this process, and they're about to sunset it, a very active and effective multi-payer table. I mean, they really have it's a true multi-payer collaborative. They did a lot of decision making together, and especially worked together in creating an mental health, behavioral health component that truly integrates with primary care. So I would say that's a huge success for Colorado. They also had a health information exchange and all payer claims database that was very effective. There's been a lot of changes. There's a lot of sort of consolidation of plans together and some plans pulling out. And so there's been some changes in Colorado but still remarkable work going on. And they really are pushing ahead with multiple things, such as primary care investment, and starting to look at measuring that and understanding that.
Perfect. And final question: what do you think are the key characteristics of a primary care transformation that are essential?
So this is my opinion, right? So we're going to limit it to that. But I think probably the most important thing for primary care practice transformation at the practice level is creating a team that actually works as a team, so that everybody who is involved in taking care of patients has the freedom to work at the top of their training, so that people are really doing the jobs for which they are trained, and also so that there is open and consistent communication among the team members to enhance the care for the patients. So things like morning huddles, that kind of, and certainly having intra-office communication that's truly seamless and is very important. Other things that really have to be in place is the patient-centered medical home. I mean, really focusing on what the patient's needs are, and trying to maximize the involvement of patients and their families in the decisions about their care. I think there has to be adequate care coordination and access to services that are truly without barriers. A quick example from Vermont, our primary care transformation really focused on what we refer to as our community health teams, in which were multidisciplinary, locally based teams of professionals such as nurse care coordinators, mental health professionals, dietitians, people who would coordinate services, including social services, socioeconomic services, and having that available to patients without any cost to them and without any cost to the practice to provide connections to those individuals. And that was paid for through and continues to be paid for through a fee that each of the participating payers contributes to. So it's a service that benefits the people involved. It's not a payment to the practice per se. So those are some of the key things. And obviously, actionable and accurate, timely information through health information exchange and claims-based data.
And probably a good acronym too. That seems quite key.
Yeah, there you go.
Well, Lisa, thank you so much for speaking on our webinar. It was a pleasure to learn from you and really appreciate your afternoon.
Absolutely. Thank you very much. Have a great rest of your meeting, and thanks for this opportunity once again.
Of course. Now it's my pleasure to turn it over to Tiffany Mattingly. Tiffany, I see you have been promoted, and perfect. Thank you for being with us this morning. So Tiffany serves as Vice President, Clinical Strategies at the Health Collaborative. She is responsible for leading high quality clinical initiatives through a diverse lens of clinical, programmatic, quality, and operational experiences, providing strategic guidance across communities, programs, and stakeholders. She also serves on the Oral Health Coalition and the Cradle Cincinnati Advisory Board, and is a member of the Ohio Organization of Nurse Leaders and the American Nurses Association and the Ohio Nurses Association, and is an active registered nurse through the Ohio Board of Nursing. Thank you so much for being with us, and I will turn it over to you.
Great. Thank you so much for having me today. Just quickly want to do a sound check. Make sure you can hear me all right. Fantastic. Okay, if you bear with me for just a moment, I'm going to share my screen and make sure that everyone can see the slide deck once it gets into slideshow. Are we good? I can't hear any feedback. Are we okay?
We are perfect. Thank you.
Fantastic. Oh, that worried me for just a moment. Great. Okay, we're in good shape. All right. So as Dr. Watkins shared a fantastic national perspective of multi-payer primary care, we are really going to drill down into Ohio. And she gave kind of a sneak peek of where we are with ambulatory care sensitive condition admissions through the CPC Plus project. And we'll get into that here in a little bit. But really what I would like to share today is our journey, this discussion around the Health Collaborative's journey to a multi-payer claims database and why that's important in supporting primary care transformation and value-based care, and the importance of that payer and practice collaboration and that joint recognition of the value of a primary or a multi-payer claims database to support primary care transformation and value-based payments. Then of course, the data-driven results are incredibly important as well. And those wraparound services around practice facilitation and data coaching and practice coaching that really helps tie all of this together. So I'm going to walk us through this journey today, and I put it in this little map kind of to help organize my brain. So there's a lot that happens here, and I wanted to try to chunk it into little pieces for everyone. And so you'll see throughout the course of this presentation in the right-hand corner, which area we're talking about. Actually kind of just cut and paste. If we're talking about building the foundation, you'll see that in the right-hand corner, et cetera, to help guide us through this presentation today. So we'll first start talking about the recognition of the building foundation and recognizing the assets to a multi-payer claims database. That's incredibly important to understand what are your assets within your organization, within your state, within your community that can help be that launching pad for a multi-payer claims database within your geographic area. And then really going into then, of course, the engaging the payers and the practices and understanding that need, is there a need? What is the need for data? What is the need for practice transformation and value-based care within the community? Where are the gaps? And then identify the challenges to meeting those needs, coming up with the collaborative solutions, sharing that value, and then really getting into the sustainability of a true multi-payer claims database. So that's what I'm going to try to walk us through in a very quick 20 minutes today. So just a little bit of background as we talk about recognizing our assets and really identifying, our building that foundation. Wanted to provide some context about who the Health Collaborative is. And we have a pretty interesting history and a great example of how kind of breaking down silos and coming together for the common good under the spirit of collaboration can really help move things forward. And that's really what we did through these three organizations. That was the Greater Cincinnati Health Council, the Health Collaborative, and Health Bridge. So the Greater Cincinnati Health Council was founded in 1957. At the time, it was 15 Cincinnati area hospitals that voted to establish this council with the visionary shared goal of providing the best in hospital care and service to the community. At the time, Cincinnati was growing at a rapid pace. So there was a lot of research and environmental scans conducted around the, just the full growth of the Cincinnati area, the economic development, the population development, the where the transition, the movement out of the urban core into the suburban areas, the strategic placement of new hospitals. And so now we have 34 hospitals in this Greater Cincinnati area that are members of the Health Collaborative. But back then, we were starting with this core, and as it was recognized that we needed more to ensure that the community was going to be taken care of and have access to high quality healthcare. Then the Health Collaborative, which is our legacy organization, was founded in 1992. And this is really who we are and the essence of who we are today. A convener of multi-stakeholders in health and healthcare, including health systems, health plans, employers, consumers, community-based organizations, public health, just a huge group of multi-stakeholders to address widespread structural problems in Greater Cincinnati's health arena. And that's really how we operate today. We bring together people to help solve problems that they couldn't otherwise solve as efficiently or with such high quality if they were going to come at it independently. Then Health Bridge was founded in 1997. The Health Bridge is a national leader as a health information exchange, really working to improve healthcare quality, efficiency, and outcomes. Really, connecting that triple aim through the connection of information across the healthcare community and really across the region. In 2012, we came together as a partnership, the three organizations. We had one CEO that governed our, was over the three organizations, but we still had three separate boards. We had three separate budgets. It wasn't very efficient, and we were still operating in silos as those boards had their very own, distinct vision and strategic plans. And so in 2015, we merged under that legacy name of the Health Collaborative and gained a lot of strength in this area to really bring the data informatics capabilities of Health Bridge and our health information exchange, the experience and reputation and trust as the multi-stakeholder collaboration, and then just kind of the heart of clinical quality and quality healthcare throughout the community through the Health Council, and just that true trust and foundation that was really built through the Health Council. So with all of that, we were very primed to be in a position to help support the development and growth of a multi-payer claims database. So who we are today is our vision is that Greater Cincinnati is healthy by design. Everyone's connected to quality, affordable healthcare. And our mission is to lead data-driven improvement that results in healthier people, better care, lower costs, or as we all know, the tripling. So just a bit about our portfolio. Our technology services under HealthBridge is what we call our HealthBridge suite, or our HB suite, and that is all of our health information exchange information, from notification of admission, discharge, transfer, and lab results, radiology results, direct messaging to physicians. All of that sits under our technology arm. Significant area sits in population health. We run the health community health needs assessment for all the hospitals. So again, efficiency and quality at the core, that if we are conducting this for the hospitals, we can be much more efficient across this assessment and put out one report for the community to leverage, one source of truth. Workforce innovation is another huge area, and of course, workforce pipeline everywhere right now is a significant concern. So to have this foundation built has been really helpful. We've been working closely with our health systems and other employers to help build up this pipeline and solve some of these immediate gaps that we have in our healthcare workforce. And then our other service programs. So CPC Plus, you can see sitting there. We had CPC Classic as well, focusing in on primary care first. We run the COVID response for the Southwest Ohio, so 8 counties in Southwest Ohio, and testing and vaccination through the Test and Protect program that's funded by our county here in Southwest Ohio, Hamilton County. So with that, that was really kind of the foundation. This is what we had to build from to help achieve this vision of a multi-payer claims database. So up next was really engaging payers and practices and understanding the need. And some of that happened organically through our awards of the CPC Classic and CPC Plus program to support those programs regionally. So the Health Collaborative supported the 75 practices in Southwest Ohio with CPC Classic, and now we support the 550 practices across the state of Ohio and Northern Kentucky for CPC Plus. Through that, we had the opportunity to really start to bring together both payers and practices separately and together, and have more of those collaborative discussions around understanding what is the need. We were able to bring together multi-stakeholder meetings where we had payers and practices in one room, talking about the difficulties around, as Dr. Watkins mentioned, having to meet the needs of each individual payer, the efficiency behind that, and the attention that's taken away from the patient to meet the needs of the payer doesn't necessarily help meet the best quality and outcomes for the patient. We have other project-based engagements around employer programs that we're running and other payer convening programs that we're running. And so we have a lot that's housed in the initial discussions for multi-payer claims database, but then also helped support the actual execution of that database. So we were able to build a database in a vacuum, basically, through the CPC Classic and CPC Plus project, because it was a really identified need at that time. Then working with the employers, identifying that the same need would be very helpful for the employer program as well. And then into payer convening. We also had the opportunity to run data reporting work groups for payers and practices, and we were running bi-monthly individual calls with payers and practices. And then we had the expertise in-house to do data coaching for payers and practices. So all of those things were assets and an opportunity and a platform to bring people together to identify what is it that we really need to help move value-based payment forward, help move practice transformation forward, and ultimately improve the outpatient outcomes. So, and when it came to data, it was identified, we need a lot of different things here, but having access to different levels of data, static views, access to an all data portal, access to flat files that systems could put into their own portal, that there needed to be flexibility to meet the needs of the practices, understanding that we're working with independent practices and we're working with large health systems. And as Dr. Watkins mentioned, you know, CMMI is really starting to focus on the equitable access of these demonstration projects. And when you look at FQHCs and independent practices and those who are serving, you know, medically underserved areas, it's much more difficult for them to participate in these practices. Number one, FQHCs weren't even eligible for CPC Plus because it's a different payment. You know, they're already under a different payment model. But making sure that, you know, there's equitable access for those who want to participate but are concerned about assuming such great risk. And then with that, we need to make sure that we have data that that individuals can take in and digest. And then, of course, providing the data coaching to go with that. A huge, when we get to solution-oriented results and identifying our transparent challenges, coming up with what this kind of model was going to look like was very collaborative in regards to, we knew that it was something that a co-ownership was incredibly important. It was an investment across payers and practices. They co-own the data. They purchase into it. It's their data. It's not the payer's data. It's not the practice's data, but they helped develop what this data was going to look like down to the risk model and the data definitions. And I hate to say the word attribution, but down to the attribution versus the empanelment and how we can help work together and even just listen to the concerns and see what we can do to try to come up with some solutions there. There was one source of truth for the practices. So back in the CPC Classic days, payers were required to give practices data. So practices were receiving, you know, sometimes 7 or 8 data reports on a monthly basis from the payers, and they had different definitions. They came in different formats. There was no way to aggregate the data. It was very difficult to see a comprehensive view of all the patients across the program. And so having that one source of truth back to, you know, efficiency and being able to really identify the impact that a practice or a system's having by participating in the program was, you know, really realized through the data aggregation and the multi-payer claims database. And then recognize that personalized support. That was the challenge, as I mentioned, just being able to, there's so much data, being able to work through it and understand it to make sure that we had support, wraparound support available. Of course, this didn't come without a lot of challenges. The risk model, the attribution, I already mentioned those, the data lag, everyone understands the pain of the data lag with claims data, conflicting priorities, especially as we move away from CPC Plus and we look into the sustainability of this. As I mentioned, this is a model that we built to support the CPC Plus demonstration project. As that comes to an end, primary care first is kind of a different animal in a lot of ways. The sustainability to shift this straight into primary care first isn't going to be without its own barriers. And so we're working through that as payers and practices start to move in different directions as you know, things get shook up a little bit at the end of CPC Plus. And that's where we have that project-based challenge as well. And then customer support and user experience. As this was all being built out, we were supporting practices and their transformation efforts in QI. We were supporting payers through how to get their data submitted. But then when it came to the end result and the user experience, I'll shamelessly say we lost sight of that. And that's something that we're really looking at now to enhance that customer support and the user experience with those data reports, with even just the login into the platform and how to use the data and what does it all mean. So a lot of lessons learned there in that last bullet. So sharing the value, when we bring together the payers and the practices for the data reporting work groups, or bring them together for the CPC Plus learning sessions, we share the value of these reports through being able to look in aggregate across all 560 practices, being able to look by payer type, and being able to bring everybody together and have discussions about what they're seeing and what they're experiencing. We can get down to the care team, so they're equipped with data. There's comprehensive views that for the attributed population in one report across multiple payers. You can get down to the payer level detail, optimize workflow, and where the practice support comes in is really helping them do all of those things, right? Helping them generate kind of a hotspot list or a high utilizer list, and then bringing together the sharing of best practices as practices start to dig into those lists and make improvements and define and refine their care management to help support those patients. So just a few examples of, this is one of the static images that we provide to all the practices, and this is a practice level report. You can see there's a count of members at the top, a count of practices, a number of providers. We use the Johns Hopkins risk score, right? You can see in this example, it's 3.27. That scores on a scale of 0 to 5. And we look at all the same measures that CMS deems important for the CPC Plus project and for the retainment of the performance-based incentive payment. And if you look down below, you can see, in the blue is the actual practice, and down below is the practice compared to all the other practices in the region, so they can kind of compare their performance to others, and then they can look at their performance by payer type. And as Dr. Watkins mentioned, there's we have great, NPR's done great statistical analysis around CPC Classic and into CPC Plus for Medicare, but we don't have a full view of the all payer data across this program. And so this gives us, at least in Ohio, again, in this vacuum of what was the what were the outcomes and the trend, what do the trends look like across the commercial and the Medicaid payers as well.
Tiffany, I hate to interrupt all of your wonderful knowledge, but I just want to give you a quick time check. We are running.
Oh, yeah. Okay, sure. I have about 2 slides left. Thank you so much.
Yes.
Yep, just want to share just quickly the comparing the practice level data to maybe a system roll up, practice on the right, a full system roll up on the left. And this is kind of more actionable use of the data, where you can see multiple practices in one system across the bottom, and their ED to PCP visit ratio. So if you look at that practice on the far right, they have many more patients that are seeing the ED than they are seeing their primary care physician. So then you can dig into that particular practice and identify those high utilizers and start to put together that high utilizer report. And then, as Dr. Watkins mentioned, the ACSCs, really seeing some great improvements here. The COVID year 2020 really is affecting the data, and we're still working out how to adjust for that and how to normalize that year. So you can see that we have a line there at the end of 2019 before going into 2020 of where we were with ACSCs at that time and the projected outcomes there. So I think that is my last slide, is really just to, our next step is to finalize payer and practice support models, complete measure specifications, enhance clinical and claims integration, secure payer and practice participation, and continue these engagement efforts to see where we can take this next in regards to sustainability.
Well, perfect. Thank you so much for speaking today at the webinar. I think we're going to ask questions at the end to give our boots on the ground panel and Dr. Transu the time to speak. And Tiffany, I hope you're okay if we reach out to you later with questions in the future.
Sure, of course.
Thank you.
Thank you.
Thank you so much, Tiffany. Such great information. And just a reminder, I know we ran through some of those data-rich slides at the end. These slides will be going out to all of you to look further in depth. And then again, if Tiffany is able and willing, we'll be submitting some questions that we receive from you to her. So now we're going to turn things over to our local leaders to provide some insights into what's happening here in Washington and what challenges we face together in achieving multi-payer alignment. We will start with Emily Transu, Associate Medical Director for Clinical Quality and Care Transformation with the Washington State Healthcare Authority. Emily is a graduate of Dartmouth Medical School and did her residency and chief residency here at the University of Washington, and she's been leading our state's multi-payer primary care model efforts. She will give us an update on this model before leading a panel discussion with three additional local leaders, Angie Sparks, Michael Mint, I hope I'm saying that properly, and Christine Palermo. Angie is president of the Washington Academy of Family Physicians and serves as the medical director of clinical knowledge development and support with Kaiser Permanente, Washington. Michael is the physician executive for Multicare Connected Care with Multicare Health Systems, and Christine is the medical director of business services with Virginia Mason Franciscan Health. So welcome, Emily, and panelists. Thanks so much for being with us today.
Thanks so much for having us. It is a pleasure to be here. I'm sharing my screen. Is it coming through?
Yes, it is.
Okay, good. Thank you. It really is great to be here, and it's been so fascinating to listen to the folks who have spoken and really think about the common themes. I'm going to go through a lot of information really quickly here, for which I apologize. It's hard to balance wanting to give an update on the work that we've been doing, but also make sure that we have time for our panel. So I'm just going to very quickly go through some information about what is happening with the primary care model here in Washington. I think we have a little envy of some of the work that's been done elsewhere that has been going on for so long, and we are building similar kinds of supports. So we have been working for quite a while now on a primary care model for Washington, and our goals with this are really to align payment incentives and metrics across payers and providers, really promote that team-based care that we heard Lisa talking about earlier, and think about all the different components that go into primary care, look at improving provider capacity and access. Over time, increase primary care expenditures while decreasing total health spending. Interesting discussion on that earlier as well. And really work with interested both public and private employers to spread and scale this work throughout Washington state. So our goal is that this be very much a statewide effort with statewide participation. To that end, we have been gathering people. This was a diagram of some of our earlier work in really bringing people together. I won't go through this in detail, but we've been gathering the major payers in Washington state and a number of provider groups, both separately and together. That led to a memorandum of understanding around some general principles in September of 2020. We have continued to work on really building consensus and have had continuous meetings with payers, with primary care and other stakeholders. We've realized that some specific pieces of work really required special attention, like talking about data. So this sort of gives you a sense of how much consensus building has gone on around this model. The outcome of all of this slide will be familiar to those who have been part of our process. Really, these are our 7 principles, working around alignment and financing, really having the providers work around capacity and access and use of analytics. Our goal in this is truly integrated whole person care and a shared understanding of care coordination and where providers fit in that. And we really want something that we can achieve value out of and measure value out of. I've highlighted alignment because I think that's both our theme today and also, in a way, the hardest piece of this. Everybody's kind of on board with these principles, but not necessarily with the idea that everyone should try to do it similarly. We have a payment model which would consist of a transformation of care fee for practices in the early stages of this work up to the first 3 years, really focusing on shifting to a prospective per member per month comprehensive primary care payment that would cover all of the costs of basic primary care. That's the goal of this payment model. And then performance incentives would be available with a combination of clinical care and utilization measures. As I said, those transformation of care fees would be available for up to 3 years for practices that are not yet really there, but really working along this journey. We have developed and refined a list of clinical quality measures. I won't go through these, they're familiar to many of you, and these are also part of our common measure set. So that's another piece of alignment that we are being very careful to bring in. We have a number of accountabilities for providers within this model, and this is something that we've really been refining with the help of a stakeholder survey and a number of meetings, really wanting to know what are we expecting from people out of this model. And these will seem, again, like familiar themes from all the discussion we've had today: team-based care, risk stratification, components of behavioral health, care coordination and strategy, access, culturally attuned care and equity. We're all very much thinking about those these days, looking at data capacity, looking at alignment of metrics. So we have been working on refining these from our initial list and building more meat around the bones of these expected accountabilities. And what do providers need in response in support of that is another thing we've been working really hard to develop. And again, without belaboring these, people can spend more time with the slides later, but really understanding what's needed from a data standpoint, all of this ongoing discussion around actionable claims data, utilization data, the importance of having a TOM tool and reference where providers can access this, the importance of care notification and coordination. And then we've talked also a lot about what do common tools and training look like that providers will need in order to implement this model. And again, more details here than we'll go through right now. There was discussion in an earlier panel about the efficiency of having a single group really looking at are people reflecting the model, and Tiffany talked about that for Ohio, and that's been a very active conversation here too. We're proposing to have a centralized provider certification for this, which would be led by HCA or HCA's delegate to really understand, are providers ready to be in the model? What level are they participating at? So we wouldn't have to have a separate assessment by each health plan, which would be incredibly burdensome for providers. So that is a process that we are actively developing right now. There are a number of components to that. I won't go through all of these, but the thought is to really have that start as more of a self-attestation in the earliest stages and then become more robust as people move into the point where they're getting the PMPM. We want this to be not overly complicated. We want it to reflect major priorities, really be using it to promote forward movement of providers as they become more sophisticated at this work. And it would recognize other primary care achievements such as PCMH certification. So we really want to avoid duplication here. And our general timeframe on this work, we are working to develop, refine, and finalize the details this year. We'll have a model out for public comment at the end of this month. Next year, we'll be moving more and more into implementation, and our hope is to launch the first cohorts of this in January of 2023, and then continue expansion across that. Several components of this model will probably be phased in terms of who's participating, in terms of business lines to the plans, certification, and provider supports. This is sort of a graphic of that phased implementation. They're going to ask for kind of the final what slide on all of this work. So really, where are we now? I think what we're doing now is we've got great principles. We are working to add the details that are needed to actually implement from those principles. And part of that is continuing to define what is standardized versus what's individualized across payers. So where does everything need to be exactly the same versus where is it okay to have the same general principles and approach, but a certain amount of individual implementation. And what do we need to keep moving? I think, first of all, we just really need the continued commitment of all stakeholders in moving this forward. And that includes providers and provider systems, payers, purchasers, employers have played a really critical role, obviously patients, and of course, the role of the state. And we need really hands-on engagement in the constructive process. I think it's very easy to say, well, this is a problem, this part won't work, this won't work, but really figuring out how do we address those roadblocks, how do we stay committed to finding solutions, even if they're not quite perfect, and recognizing that alignment means that everybody has to move. It's not just everyone should align around what I'm doing, but how do we all get there together? So that's a very, very quick overview of where we are with the primary care model currently. I want to move on to our panel, but if people have questions, feel free to reach out. We've got lots of additional information up online and are always happy to have questions.
Emily, it's a tad hard to hear you, especially when you turn a little bit away from the camera. So just wanted to kind of put that in there as we go toward the panel discussion.
Thank you. Sorry about that.
No problem. Thank you.
So we will move on to the panel, figure out how to stop presenting. There we go. So we have a few questions set up for the panel. Maybe we could have everybody turn your videos on. And we'll start with some initial panel questions, but we really want this to be interactive from the audience as well. So feel free to put questions in the chat and we will move from there. So first off, interested in hearing from everyone, what are some of the barriers that you and folks in your organization have faced when you're trying to align payer strategies? What's been your experience of that and how have you dealt with it? People can jump in or we can go around the room.
Emily, I can take that one to start with. And I'll be changing hats as we're talking because I do work at Kaiser Permanente, but I'm also here on behalf of the Academy of Family Physicians. So I'll wear the Kaiser Permanente hat for the moment, which is as a already value-based payment model, we do have an extended network in the state. And so when there is variability about how much fee-for-service is occurring with our different practices that we are cooperating with and trying to do that across the state in different regions, it is very challenging to not have the alignment in different places about what value-based payment is and how much of it is happening, and then how much of primary care is being funded in a value-based way. So that's one of the bigger challenges.
Yeah, this is Mike Mint. I'll only just say thank you, Angie, for saying that Kaiser also has these same challenges, because oftentimes we tend to look at Kaiser as one of the models that maybe have fewer variations. We're in the same boat, and I think that I'm probably not telling anything to this crowd that is new, but we live in a fee-for-service and a fee-for-value world, and Multicare has really worked hard to take on more value-based arrangements and move in that direction. And yet we've acknowledged that we will be in a fee-for-service, fee-for-value mixed world, just in different proportions. And trying to live in both, I think that even the 1 foot in each canoe underestimates the challenges of care transformation in both of those spaces. And I appreciate sort of the approaches from all the speakers today, because I think that only through coordinated efforts with this multidisciplinary approach can we get there. But we're working through PCMH models. We're working with how we compensate and pay our providers, how we organize our care delivery models. And it's interesting thinking about multi-payer primary care models as an integrated healthcare system, similar to other groups here, how we engage our specialists and others so that this isn't a primary care as just a different way of siloing it compared with the rest of the care model across the continuum, and trying to think of how we can deliver high value care across the continuum. And my only last comment is that there are a lot of disruptive forces coming on in, funded by private equity and others, that also we have to sort of be cognizant of and be responsive to, and whether partnership and or competitor or any other models out there. It's a very complex world out there with a lot of kind of deep pocket other groups coming in to sort of I think have opportunities in different spaces. And we feel that as an integrated healthcare delivery system, we can deliver comprehensive high value care, but we're adjusting and evolving like many other groups are.
And this is Christine Palermo with Virginia Mason Franciscan Health. Also very much appreciate the comments by Dr. Sparks and Dr. Mint. And I would add as well that is one of our greatest challenges, is in addition to needing, the source of truth, that one place where we can access data so that we understand how we're being perceived in the marketplace, as well as the various ways that we're being measured in the different metrics. I would say the greatest challenge is the fact that, to what Dr. Mint was just speaking about, is that the vast majority of our provider systems, ourselves included, do have 1 foot in value-based care, 1 foot in fee-for-service, but therein is also the opportunity, because that activation energy hump that we need to get over to be able to transform and transition our care practices is actually revenue. And that is where the opportunity to partner with payers as well as employers makes a big difference. Because if we can change the way that payments and reimbursement come through, and I can speak to a specific Virginia Mason model that I think many have probably heard of, it's kind of a classic model around back pain. We have been able to innovate in that space to reduce costs, reduce utilization, and simultaneously improve outcomes, from the patient perspective, the employer perspective, as well as utilization perspective from the provider's experience. So that would be the specific barrier, I think, that a lot of provider groups are experiencing.
So interesting themes. Clearly, that common data, common platforms is a very strong one. There was just a question in the chat about where the APCD stands in Washington right now. It is increasingly kind of generating data and being functional, but not yet in that place where people can just turn to it for that role. So I think there's a very active set of conversations going on around what would that look like. So lots of thoughts on data. What else do you wish that plans and purchasers would do together better to align in their strategies?
Well, I can tell a brief patient story. Dr. Mint was talking about kind of the disruptive entities as well in this. And getting back to medical home, which has been really challenging with some of the disruption of the pandemic too, had a patient just briefly who was new to our insurance, but unfortunately didn't get impaneled with anyone in that. And so had kind of a mental health crisis and didn't really know where they should go for first contact or medical home, even in our system. And instead saw an ad on Facebook and reached out to one of these groups, was put on pretty inappropriate care, had a bad side effect, and finally came into the office after experiencing the negative outcome to say, I really can't coordinate my own care. Basically, what they'd been trying to do is build their own team and their own behavioral health team, and it just didn't work. And I think one of the things that would be very helpful, we're talking about attribution in data too, is if we really did insist on empanelment, that we have to know where the home is if we're going to measure if it's providing quality or not. And we have so many folks in the state right now who are kind of, trying to build their own primary care team without the guidance of whatever system they're finding themselves in.
Yeah, and I guess I'll maybe jump in next. I think that one of the biggest challenges that we have is that we know the problem. Like, I don't think that, and I think you said this, Emily, in your introduction, is like we know the problems. And I think Christine really mentioned this well also, that we also know some of the solutions, right? Some of the solutions is how we do the funding model and be able to fund medical homes. Part of what Angie just mentioned, is an access issue. There's primary care access issues throughout the state right now. And we would have to, what I would maybe say to your question, Emily, of what a coalition of payers, and not just insured payers, but any payer, the state and others, Emily, with HCA, like trying to create a funding model that then allows the balance of sort of the directed funds, which are helpful, but don't necessarily aid in transformation. And I was, obviously very interested in the transformational funding and how we can start to come up with a common medical home model that then the funding can support in a way that then the payers and the providers can have a shared expectation on what the value outcome is. Otherwise, it ends up in a very fragmented way, as we've all and all the prior speakers mentioned, in regards to varying data sets. And then, you do this widget here and you get paid that widget there. And it's very confusing from the healthcare systems. It has to be more foundational. And then with, shared more broad outcomes in regards to the shared data set and shared value sets, that would be sort of from my perspective.
And then just to build on again to what Dr. Sparks and Dr. Mint were mentioning is I'll just go ahead and give the classic Virginia Mason example just as an example of framework in which, I'm hoping that our colleagues here can kind of hang their hats on. And this had to do with back pain. And I do, of course, want to give a shout out to my immediate past predecessor, Dr. Bob Mecklenburg, as well as my colleague, Dr. Andrew Friedman, who really spearheaded this work. And I'm just speaking to it as an example. But in regards to back pain, one of our earlier speakers talked about identifying hotspots. This hotspot was identified obviously in primary care, as well as the emergency room, but you can believe that the employers were also noticing reduced productivity in their employees because they were going out for this complaint of back pain. And of course, the payers were noticing some increased costs in that area as well. So that's an example of the shared recognition that there's this hotspot and how data can really drive that. However, when we did that deeper dive into the issue, what were the drivers of cost? And there were really two drivers. One was inappropriate utilization of things such as advanced imaging, ER visits, pain medications. But from the patient and the employer perspective, it was reduced productivity. They wanted to go back to work. Both the patient, and the employer, they also wanted to be in less pain. Let's not forget the patient experience. But through a collaborative of the provider group, which was us, a large, very forthcoming national insurance group, as well as a large employer group, we were able to create alignment. So this is to your question, Emily, is what kind of activities do we wish employers and payers would be more aligned around? But we created alignment around the issue, the standards in regards to evidence-based practice, and then the standards of what is considered valuable to all of the stakeholders that were involved. And so long story short, the consequences of this was that we recognized through evidence-based medicine that x-rays, MRIs are rarely needed. Predominantly, patients need a therapeutic trial of physical therapy. There was a question earlier about, so who lost the revenue and who gained the revenue in this situation? We lost revenue from a radiology perspective, but to make it sustainable and accessible to patients, that's another metric, is accessibility, is the payers and the employers did agree to reimburse physical therapy a little bit more so that it was sustainable for us. So it wasn't just cost reduction, cost reduction, cost reduction. It was actually sustainability and appropriate utilization. And this continues. It takes a lot of maintenance. I will say that it was not easy. It was years in the making. My role is to try to continue to sustain it. Again, very challenging, but just an example of what Dr. Sparks and Dr. Mint were talking about.
And I had the great opportunity to work with both Christine and Mac back in the past, and had a first line view on this. I think that what's so critical about that is thinking differently about this, and not this kind of race to the bottom with each sort of group looking in their silo and just trying to reduce cost and trying to maintain quality. What we really want to do is increase value. And at the end of the day, whether it's through more bundle type models or PMPM type models, I think engaging different wings of the healthcare system, radiologists, like that's one of the cool things that VM really did, was try to deconflict a little bit of that, and then net benefit for the patients, net benefit for the, the triple aim type goals there. And just thanks, Christine, for relaying that.
Yeah, thank you.
And Christine, one follow-up on that. So that effort has been across multiple payers.
So the initial project was across just one national payer, one employer group. They were both obviously quite large, and so it was substantial. We had the critical mass that we needed to be able to get that through that activation energy and create the process. But I will say, fast forward to the situation that I am in, and it is across multiple payers. In fact, a subset of that work that came out of it was this concept of exemption for prior authorization for advanced imaging. And so through the alignment around evidence-based medicine and appropriate utilization, as well as obviously reimbursement to support the system and keep it sustainable, we have actually gotten to that point where all of our commercial payers are in agreement that for certain advanced imaging, we won't need to go through the prior authorization process, but we will need to go through validation and auditing after. So it actually removes the waste from the system. And therein is how we experience the cost reduction while maintaining the quality. And I hope and I believe that at least for our payer partners, they're not having to pay to do that prior authorization process, as well as us having to submit the information. And we hope that that would trickle down to the consumers and the employers.
We have some interesting questions in the chat. One from John Kim. In working toward multi-payer models with competing private payers, has anyone run into antitrust issues? Curious if any of you, maybe VM, as you've been working with different payers, has that been an issue or not come up?
Emily, I'm sorry, you cut out for a minute.
Oh, I'm sorry. So some questions about whether antitrust issues has become a concern in any of this work.
I would have to say from my perspective, I'm not sure.
So we have a couple questions from the group around sort of looking at these different approaches. So there's kind of aligned measures and payment to support improvements and cost savings, and then some other approaches that are more fragmented and disruptive and don't necessarily align with other payers. And I'm guessing that the question behind that is partly about things like centers of excellence. Might be interesting for VM, who has a lot of experience in both sides of that. So asking whether people envision those being reconciled at some point, the difference between kind of the silos of excellence, which can be very, very excellent, and the question of integration. How do we work through those two?
Was that directed at Christine or?
Good question. I guess at Christine, although if either of the other of you have any thoughts, feel free to join in.
I apologize. I was still thinking a bit about the antitrust question, and especially in regards to the centers of excellence. And then Emily, could you rephrase the question? I was just trying to find it in the Q&A around integration and what the concerns were there.
Sure. I think there's a lot of value-based purchasing that is happening in a sort of integrated settings, and then there's also a lot that's happening in more fragmented settings. And I would suspect that centers of excellence might be an underlying question there. How do we reconcile those? Do we see them coming together? I can speak to that a little bit from the healthcare authority perspective, since we have some of both. And to me, it's really a question of coevolution. I think the work that we have done with centers of excellence has been tremendous. We've had great partners in that and great successes. And we're conscious of the risk of pulling people out of their integrated systems. So I think what we'd like to see is those kinds of models driving improvement across the board and really driving toward a higher level of clinical standards for everyone that can then be expected and occur within an integrated setting.
Emily, I would actually second that. At the risk of sounding a little bit academic, it does strike me as very similar to a concept that I think many of us may know about. It's called the Walmart effect, where Walmart, they're driven by low cost, always, every day, the little, yellow smiley guy that bounces across the screen. But the consequence of that is they're such a large purchaser, and their demand, for low cost forces their suppliers to enact different efficiencies into the system so that they can sell their product at a lower cost. But it doesn't just benefit Walmart consumers, it actually benefits all consumers of the product that that supplier is creating, because they have now figured out how to create their product more affordably. And then you can pass that savings on across the board. So it's not just Walmart, it could be like the Home Depots or the Costco's of the world. So just sounding a little bit academic there, but I think that does speak to what you're saying, where you can lead, you know, with creating these innovative models. But the idea there is that's just the beginning of transforming the marketplace.
Lots more good questions. One from Susie Dade that maybe each person could address a little bit. I want to be conscious of time. But so Susie writes, you've listed a number of challenges that seem common to all of these types of efforts. What have you done that actually worked to address these challenges? And what did you do that didn't work? So maybe just a quick example of some successes and not so much successes from everybody.
Thanks for the question, Susie. So just thinking about the recent pandemic experience that I think we've all gone through together, I think virtual care and how that feeds into an integrated system is really one of the success stories, especially in getting alignment with payers and purchasers and providers on what needed to happen on behalf of patients so that they had an experience where they could access care through virtual platforms, which were at that time safer and more efficient in a lot of ways. Kind of what Christine was saying, we're starting to learn some efficiencies through that are really exciting. And it does demonstrate that collaborativeness that we've been talking about.
I would say that from Multicare's perspective, one of the really interesting things that we're working on that I would say is successful to date, and we need to build off of it, is sort of having our clinically integrated network, what we call Multicare Connected Care. And we're coordinating and working deeper with almost 5,000 providers throughout the state of Washington and a little bit beyond. And really working to try and create a shared common language, shared common model, and especially working with both employed and independent clinicians. There's a great amount of innovation that comes from that sort of blended model, and we're still working to figure out how to best leverage on that. But I sort of think of the Don Berwick quote, right? The highest value care is happening somewhere, just not everywhere. And one of the really cool things that we've been working on is looking for those kind of bright spotting and sharing and spreading. And I think that's been one of the successes that we've had in a variety of different value-based models.
And I would say, just to build upon Dr. Mint's last comment, is there is, and also Dr. Sparks, that during the pandemic, and rightly so, there is an increased focus on inclusivity and equity. And it's only through partnerships with our perhaps non-integrated providers and provider groups that we can ensure we're hearing the voices of the patients that they are serving in those areas where they may not have the resources to have an integrated system. And we must partner with them and hear them. And if we are that integrated provider group, how can we share and spread the experiences, the knowledge, the data, that we have?
That's a beautiful way to end this panel. Thank you all. Thank you, Emily, Angie, Christine, and Michael. I really appreciate all of your comments and your willingness to react to one another and have these conversations and kind of learn in public, which is always a great space. So I thank everybody who attended, and am now going to turn this over to my colleague, Nancy Gento.
Ginny, thank you. And I want to add my thanks to all who have been able to join us today. I thought this was a very interesting series of presentations and dialogue. The Washington Health Alliance is really proud to continue to partner with the Foundation for Healthcare Quality for the Change in Action series in 2022. We enjoy a wonderful partnership, Ginny, with you and your team, and I thank you for that. We're going to have 4 opportunities to reflect, read, re-energize on this important topic of paying for value in healthcare. In January, we'll be focusing on social determinants of health. In April, on interoperability. In July, on aligning quality measurement. In October, multi-payer collaboration. So we're really driving now to action, working our way forward to really making a difference in our marketplace together. Thanks again for joining us. We'll see you on January 13th. Good day, everybody.